So with that, I said that Mike is the president and CEO of the National Alliance of Healthcare Purchaser Coalitions, an association of approximately 50 regional coalitions collectively supporting over 12,000 healthcare purchasers, providing health coverage to more than 45 million Americans. That's pretty amazing. The National Alliance helps to lead improvements in health, well-being, and value for our companies and communities across the country. Prior to joining the National Alliance, Mike was a principal at PricewaterhouseCoopers for 20 years. Mike is a nationally recognized thought leader for business health strategies and health system reform, which is, again, I can attest to on just everything the National Alliance is working on. He's worked with major employers and other stakeholders on sustainable cost reduction, integrated health, wellness and consumerism, retiree health, private health exchanges, and health reform. And I could go on with his bio, but I would rather hear Mike speak instead of me talking about his bio. So anyway, with that, I am going to go ahead and turn it over to you, Mike. And again, thank you so much.
Thank you, Shelley. And I have to say, I am really thrilled about this topic. I have talked about total person health in the past. And when I agreed to talk with Shelley, I think it's been a while. When we first agreed, I said, oh, this shouldn't be too hard for me. I've talked about it in the past, and I have my deck. I can probably just tweak it and I'll be good to go. But when I rethought about it in the context of the COVID-19 era, I realized I had to change so much. I had to update so much. It took me 4 hours to update this deck to be relevant in this era. And I think we're all finding that everything that we thought we knew prior to COVID-19 is getting adjusted and getting amplified and has a whole new set of dynamics that needs to be considered. And so as I go into this deck, you'll see I'm going to start with some of the slides I typically would have talked about, almost starting with the end as to where we were prior to COVID-19, but I'm going to quickly pivot and make this relevant in this era and how I'm thinking about it, and I think how all of us should start to think about it. So with that, I kind of start the journey here. So total person health, I think all of us have looked at total person health with this context of overall well-being, all those various dimensions that not just impact health and productivity at work, but actually are dimensions of our lives, right? And it's really about helping people to thrive with total person health, well-being, total person health. A lot of that gets intertwined in many ways. You see how we have mental health and mental illness. It's interesting. In many times we think of mental health and mental illness as one of the dimensions of well-being or total person health. I would also acknowledge that it's a two-way street, that all the dimensions of well-being, physical, social, mental, spiritual, intellectual, financial, all of those actually contribute to our mental health or can be triggers for mental illness. And so all these topics are intertwined, and we'll talk a lot more about that in a second. So where does total person matter, and what actually got me so excited about thinking about total person health? It's basically where the most successful things that we have done as employers, as plan sponsors, as vendors, have invariably been when we've broken down the silos and looked more broadly at people holistically. And so obviously that's true in our well-being. There's been great success in these advocacy services and navigation services that get to know people holistically and understand all the various issues in their lives and then help them to navigate the system or advocate for how they should use the resources. Obviously very relevant in your care and case management. I would argue our advanced primary care or even our on-site clinics is all about total person health. It's about not just dealing with the issue in front of you, but understanding the individual holistically and all the dimensions that contribute to their situation and their attitudes, beliefs, and circumstances, and then working on that holistically as well. I would think that it also plays into procedural type activities, episodes of care or centers of excellence, looking at things more holistically, not just looking at things academically, but understanding the psychosocial issues that impact the care that's delivered and frankly, even as we think about outcomes and performance assessment, it's not enough to get people out of the hospital. It's to help them get back to the lives they want to live. And our well-being strategies aren't just about improving their physical health, but actually looking at people more holistically. And hopefully, as we kind of go through this today, you'll get a sense of that, because it's a little amorphous. But what's interesting, it doesn't fit only in benefits. It's clearly related to your talent strategies. It's clearly related to diversity and inclusion. And frankly, it has everything to do with the business and what your employees that you're really looking for to kind of bring your companies back in the COVID era. This is what they're looking for, is this holistic view of well-being. So one of the key elements of this focus is this issue of empathy and trust. And we know that no matter which of those entities is being involved in total person health, that they will not be successful if they have not earned the trust and approached their jobs with empathy for the diversity of the people that you're confronting. Every individual has its own story. How does that come into play? And this is a survey that was done several years ago from Quantum and Limeade, looking at, and the most important cultural attributes were those things that were very focused on this relationship with employees holistically. And frankly, this issue is actually getting challenged right now. We actually have a survey that's coming out. We did a survey with Lyra just in the past month around COVID-19 and the issues around mental health. And one of the things that is coming out of that survey is many employees are not sure that their employees value them holistically right now. They know they want them to get back to work, but in our communications, we need to be very careful, and we need to be clearly communicating that the health, safety, and well-being of our employees really is job one. It's not just about getting back to work. It's about doing so in a way that supports our employees. So again, the key is this total person health and well-being. And again, these are the slides I had before, and I'm not going through all the slides I had before COVID-19, and just reinforcing that if you're thriving in all those elements of well-being, everything goes better. You have less unhealthy days. People are more likely to adapt to change, more likely to bounce back from an illness, less likely to be involved in a workplace accident. So, and so now I'm going to pivot a little bit and say, okay, well, COVID-19 happened, right? So, how ready were we? And, this was a survey that was done by Prudential back in February, before the worst of the virus came, and 54% said they were not financially prepared, meaning individuals, to manage a contagious disease outbreak that requires quarantines and limits their ability to work for several weeks. We know that our people are financially constrained, and now they're being compromised in their health as well. And the interface between total person health, total well-being, and financial well-being has never been more intertwined. And that's true of the companies themselves, and organizations, every organization, whether it's a company or a state or whatever, health and the economics are totally intertwined right now. The good news is that, or maybe it's I don't know how good a news it is, but glass half full, glass half empty. Employers traditionally have been a trusted source for information, and Prudential found 45% of individuals trust their employees for the information during a health crisis. But again, this issue of trust is going to be so central as we move forward during the COVID-19 crisis, and will always be important, but I think it's being challenged right now. Let's go to I guess I'm doing the slides. So I'm going to walk through a few slides, and I'm hoping that I get through my slides reasonably well, so we'll have time for Q&A at the end. And I just want to state some of the things that we're all seeing here And of course, I actually live in the Northeast. I live in New Jersey. I went through the first wave in a big way, and we shut down entirely. And in fact, we now have one of the lowest rates of the virus in the country because people have gotten used to a new normal around social distancing and masks. And culturally, for whatever reason, New York and Massachusetts, Connecticut appear to be much more oriented towards living within this constraint. Now, that's not entirely or universal. I mean, we have beaches in New York, New Jersey, and we're seeing some activities there. We're also seeing a lot of youth doing a lot of things independently. And so this whole issue around COVID is tricky. Now, we know that much of the country, 28 states, even earlier this year, were gradually reopening, many of whom had never actually turned the corner and brought the virus way down. And we know the circumstances of that reopening are directly related to what the future trend of the virus is. And if more than one person gets infected with the virus, when you have the virus, then the trend is always going to be up. If less than one, the trend will be down. And if it's equal to one, it'll be one. Well, what we have seen is most of the states that reopened in a way that more than one individual was getting infected by anybody who had the virus. And so what has happened is re-escalated the virus. So again, until we get this blue arrow right, we will not change the course of the virus. And I think you're hearing, leaders regionally, nationally, globally, coalesce around the issue that it's all about social distancing and masks, because we're not going to screen ourselves out of this, right? We're going to have to deal with that. Well, all of that is having an impact on total well-being as well. Obviously, there's a reason that people want to get back to the old way, because that's their life they enjoyed living. And we're trying to struggle with, well, how do we support them in this new world? And what does this new world look like? And that, I think, is what Total Person Health during COVID-19 is about. So, short-term and long-term, obviously, from a healthcare standpoint, there's been huge change in how healthcare services are being delivered. Elective surgeries down like crazy, primary care visits down like crazy, specialty care visits down like crazy. On-site clinics have often been closed because for many employers, not all employers, many essential employers have been at work right along, but many on-site clinics have temporarily closed. Medications, frankly, what we're seeing is initially when the COVID-19 hit, medications actually went up. People shifted to mail order, got bigger supplies. But what we're seeing after that is those two are going down, that when there's less interactions with physicians, there's less medications. We also know there's concerns about people being compliant in this period, actually taking the medications as prescribed. And the one thing that's up, virtual visits like crazy. So as we look forward, there are ramifications of those short-term trends, and I'll talk about that in your claims, those are down quite a bit. The health plans have had record low claims. I mean, their loss ratios are really low right now, below anything they've ever seen before. But of course, if people don't go to the doctor, there are things they need to go to the doctor for. And we're even seeing things like people not going to the emergency room when they have signs of stroke. People self-managing themselves in a way that's not healthy. And so while historically we have probably been disproportionately focused on eliminating low-value care, right now it's kind of swung the other direction, where we're concerned about the elimination of high-value care, that we need to re-educate on what do you need to do. And we have never lived in a world that where the majority of the population has not been immunized, but we're getting close to potentially that happening this year because of the fact that people are not going to the doctor at all. I say at all, that's obviously not true, but it's very material. This is not, it could be 60% or more less utilization going on now versus what has happened historically. And again, this is not happening because of the economy. It's happening because of the virus. And if the virus doesn't go away, it's not entirely clear how short the short run actually will be. That if people are afraid to use facilities, you know, we have a lot of work to do to get them comfortable to use these facilities the right way. And obviously, what can be done virtually, whether it's in our businesses or otherwise, will be done virtually. I mean, but there's things that can't be done virtually, and so how do we go there? But the other long run here is the new normal. You know, even if we were to get a vaccine next year, I don't think we ever go back. Our work has changed forever. Our lives have changed forever. Healthcare will change forever. And I actually think the employer covenant with employees will change forever. And I think we're living through that as we speak. And as we're thinking this through, you know, it's right now we're just trying to manage the day-to-day. There's so much going on, so much to know. But I think increasingly we have to start thinking more strategically, what are the implications of well-being and total person health moving forward? And so when you look at the pandemic more clinically, I think you want to look at a couple of different things. You have the immediate issue of the virus, you know, up and down. And of course, what we have seen is not a second wave, but a lack of discipline in executing against the first wave, where we've kind of reopened too quickly without any discipline, and it just keeps going up. But other things are happening, and you know, some of it is this issue related to people deferring care that may or may not be necessary, but some of it is necessary. And as they defer that care, what we're finding and expecting to find more of is we're treating things later in those conditions. So for example, if you have cancer, you may not pick it up as quickly if we're not doing screenings consistently the way we normally would be, which means that we'll be picking up the cancers at a later stage that will be less easy to treat and frankly more expensive to treat if we don't pick them up earlier, right? You know, there's so many different stories on it. We also see issues as it relates to chronic disease. One of the things we're hearing is this issue around chronic disease fatigue, where people are so tired of all the things happening in their lives that they aren't necessarily taking care of themselves if they do have a chronic disease. And if they don't take care of themselves on the chronic disease, obviously that's going to have a ramification. And interplaying in all of that is what we're calling, this says the fourth wave, we're calling it the second wave, which is mental health. That a lot of things are happening that are causing the mental health of our populations to deteriorate, whether or not we do all the right things. And I'll explain that in just a second, but a big part of this is kind of understanding the dynamics of stress. So if you understand the dynamics of stress, you understand that it's the product of demands and pressures in our lives, at work, at home, universally, right? And those demands and pressures are additive and cumulative. It's not short-term pressures that lead to mental illness or lead to other downstream impacts. It's long-term, chronic almost stress, things that don't get better, things that get worse and worse over time. And what you'll see with the pandemic is the longer we are isolated, the longer we worry about the stress of the economics, the longer we worry about the fear of the virus itself. As all those things add up, our mental health will be impacted. And we can invest and should invest in coping skills, our ability to be resilient and do all the right things. But the science, the studies, the economic studies that have been done, Lyle Miller from the Biobehavioral Institute of Boston did an econometric model, and he found those coping skills predicted 16% of the outcomes. But those demands and pressures that I just spoke of, they predict 60% of the outcomes. So no matter what we do to help our people, it's going to get better. It's going to get worse. And we need to be all hands on deck on the mental health parts of this equation. And so when we think about the emotional and population health, we need to think of all the elements of well-being. Remember how I said well-being is actually the root cause issues of mental health, stress, and anxiety. You know, well, it turns out if you're more physically active, you're going to mitigate your risk. If you get your sleep, you're going to mitigate your risk. The more socially connected, you're going to mitigate your risk. The more purposeful your life, you're going to mitigate your risk. All those elements. So well-being and mental health go hand in hand. And frankly, we can't avoid some of these things on the right, the economic stress or the fear of COVID or social isolation. And we see people bouncing back and forth between these. If, you know, when they're sitting at home, they might have less fear of COVID, but when we bring them back to work, that might be higher on their list than when they're sitting at home, right? And social isolation, obviously that's happening more when people don't get a chance to interact with other individuals. And that might be mitigated when they go back to work, but now other things enter in the forum. And then of course, if they get laid off, it's just a big dynamic. And it's not limited to that dynamic, because we know that the people who are working at home or working at work are also having additional pressures around caregiving and their parents and, deaths in the family or friends. A very complex picture of what's happening from an emotional standpoint. And that's having an impact on everything. We also know that there's issues from a population health standpoint. And a lot of the issues that we need to be aware of physically around the virus are disproportionately hitting people, but also indirectly, our management of some of those issues are also getting complicated by this environment, not limited to the virus itself. So the cultural and ethnic differences, age, chronic disease, minorities, social determinants, all that. And I'm going to talk more about those. But then there's special situations like people who are pregnant and other types of issues that we as health professionals, benefit professionals, need to be aware of. And, you know, bright spot in this is virtual health support. We've never seen anything explode like this. And we are learning to do things virtually that we've never done before. And I don't think we ever go back to doing some of that stuff in person, if we could do it virtually, any more than we're sending people back to work who can work at home. So this is a key issue as we move forward. We have been doing a recent series, the National Alliance has been doing a recent series working with One Mind at Work and Total Brain on a mental health index that's looking at what's happening to mental health in this environment. And these are charts from what we did last Friday. So these are fairly current. They're from June. And you see June actually came down in terms of the risk of mental health conditions from where it had been in May. And a lot of that has to do with the fact that June was a period when the economy was reopening, right? Everybody was getting back. You know, we're part of it. You know, we're back into the restaurants, back at the beach. All those good things were happening in June. And of course, in July, increasingly, we were paying the price for what we did, right? And so we don't think these are sustainable. But even with that reduction in June, which is probably not sustainable, you're seeing a 41% increase in the risk of general anxiety. You're seeing a 54% increase in depressive disorder. You're seeing a 49% increase in PTSD and post-traumatic stress disorder. And so all of these are, it's clear that what is expected in theory is happening in practice, and this is likely to get worse. It's likely to get worse. And if you put that on top of a system that wasn't particularly effective before in supporting people's mental health, both due to the stigma and those type of issues, but also because of the lack of access and quality of delivery, healthcare delivery, this is a crisis. And it's one that's going to be as important as the virus itself. And I'll also point out that while there's this bias in the virus that it's hitting, you know, older people disproportionately, I would tell you that for this mental health issue, it's hitting younger people disproportionately. And so this trade-off between, and that's a conversation I'd love to have, I've had it, but you see that it's much worse for younger people, and frankly, much worse for females than males. And I think that really speaks to the broad role that women play in their families. So again, when we think about COVID-19 emotional and caregiving support, there is obviously a lot of activity, and this, everything we do in the COVID-19 era is dated. This is in March. That was 3 months ago. Therefore, it is totally out of date. But at that time, there was a lot of people that were putting special support for emotional risks, and a lot of people looking at that issue. I think if you're not looking at this, you just haven't seen this trend as thing. This has to be on your radar. And similarly, caregiving, which we're going to actually do another COVID-19 town hall later in August on this issue of caregiving. And, a lot is related to the schools. It's also related to the parents. It just has complicated our lives in ways that we've never seen before. It was always there, but not at this level of demand and concern for total person health, total person well-being. And then the other thing I'd want to stress is that we're all in different situations. No matter what our organization looks like, it's a different situation by organization. If you're in finance and insurance, for example, you will find that most of those employees can do their jobs effectively at home. But if you're in retail or you're in healthcare, that's a lot less. And frankly, it's a lot less likely your hourly staff, your lower paid typically staff, can work from home than your executives and your salaried staff. They are often working at home. And that disparity between what our low paid experienced workers are experiencing and what our higher paid people are experiencing is contributing to a concern. I think it's part of the trust problem. It's part of the inequity issue that we're all seeing. But you can see it across industry too, right? In every instance, a far smaller percentage of the workforce who are hourly can effectively work at home, whereas salaried, in many industries, most salaried people can in fact do their jobs effectively from home. I'm at home right now. So let's talk a little bit about that cost of the mental health comorbidity. Oops, let me go back. I think I lost it. So, a lot of people would say, boy, this is going to cost us a lot. The mental health costs are going to exacerbate. It turns out the costs of mental health are a very small percentage of our costs. Those direct medical costs from mental health, it's less than 5%. It's not a big number. And so even if that blows up, it's not the end of the world. The bigger concern is what it does to everything else. And you can see that the higher costs of comorbidities are more than double the direct medical costs when mental health goes up. And you see this study from Livongo where if they had the cost of a person with chronic disease only compared to somebody that didn't have chronic disease or behavioral health, it's 2.5. But if you add the behavioral health in, that number grows to 9.4. And how many people have chronic disease? And if they develop mental health issues, what's going to happen to their cost? It turns out that 9.4, it's not on the behavioral health side. It's on the chronic disease side. It's on that side of the equation that it goes up. And we're going to see some of that data coming out in the study coming out from Milliman again in the next couple of weeks. You're going to see more on this shortly. So it paints a very complex picture, right? Where you've got people working at the work site, working at home, furloughed, and you see, the direct issues of the COVID-19 virus, the indirect issues on mental health, and the third issue around total person health, the issue around higher risk for those with chronic disease, the impact on the comorbidities, the social determinants and health equity. And all those risk factors that we've historically focused on in our population health strategies, they're all at risk, every one of them. And sometimes they're changing, right? So ergonomics, we used to focus on ergonomics in the workforce, and now we have to worry about ergonomics at home, right? Diet has changed. We know addiction is up. Sleep is being upset, all those issues. So it really has complicated how we're looking at this. So where is healthcare delivery in this? Let me pause for just a second. First of all, we have never seen healthcare impacted by a downturn in our lifetimes. Never. So what you see on the right here is what happened during the Great Recession. You remember the Great Recession? It was the biggest recession since the Depression. And you see the blue line? That was healthcare. Not a tweak. Not a tweak. When I was at PwC before I had this position, we did a behind the numbers looking at the prior during the Great Recession, we looked at the prior 30 years as to whether or not healthcare was impacted by a recession. And the conclusion is healthcare is recession proof. Healthcare has never had a correction yet. It turns out, and I heard this from, we had a speaker at our conference from Commonwealth Fund, and he said, you know, healthcare is recession proof, but it's not virus proof. And healthcare is being impacted by the virus big time. And so the question is, what will happen after the virus? What will happen as a result of the virus? Will we ever go back? Will it get back to what it was? Or is there a new normal around healthcare delivery? My view, virtual care is going to go way up. This is not going back in the bottle. Advanced primary care, I think we have new respect and need to double down our investment in primary care. And while primary care is really in very dire straits right now because of these lack of visits, we as purchasers need to double down on primary care. We need to go to new payment models and not do less, but do more primary care. We need people to get that high value services, and we need to get them out of the middle of making decisions about their own health because they're not making very good ones. Primary cares are our partners in the new system. And they've always been our partners, but I don't think we've given them their due respect. And I think you may have seen that the National Alliance is working right now with the American Academy of Family Practice to improve and sponsor advanced primary care with coalitions and employers across the country. Movement to outpatient, no doubt. Focus on high value prevention. Again, we've kind of given lip service to prevention, but I think with the amount that is not happening, we need to better define what is high value services, and we need to double down our education and our metrics on high value because it's not happening because of the virus. Healthcare literacy and advocacy, I apologize for the typo there. You know, people are making decisions on their own and they're not making good ones. They're staying home in light of symptoms of a stroke, right? That's not health literate. That is a bad thing. Even if they recover from the stroke, they will have lifelong disability if they do not react when they have these symptoms. We need to double down on education around that. And advocacy is one of the ways we can help them make shared decision-making more systematic in our approach. And then finally, I think we are going to see more regionalization of centers of excellence, that there's going to be more specialization, and we're going to pick our partners. Not everything is going to be done in institutions going forward. And when they are done, we're going to look for more accountability and more holistic support around that. And this is where that value-based total person care, where it's integrative medicine, kind of integrating all the elements of an individual's circumstances into the services, outcomes, not just focused on getting people well for the condition here, but looking more holistically around their overall condition, if you will. And then social determinants, looking at the inputs, you know, what's been characterized by Rishi Manchanda as upstream medicine. And all of this ties into the value agenda going forward: transparency, affordability, quality and safety, waste, et cetera. So we talked about traditional primary care in trouble. This is very, very serious issue, not for primary care, for all of us. We need to double down in supporting primary care. They are the backbone of this system going forward, and they need to survive this. And we need to align not with traditional primary care, but this advanced primary care. And we have identified these 7 elements as being critical: enhanced access for patients, more time with the patients, realigned payment, infrastructure backbone, discipline focus on population health, behavioral health integration. Again, the idea that we call something a medical home and behavioral health is not integrated is a crime. And then referral management. We can do a lot less care outside of primary care if we double down our investment in primary care. And then institutional care, I think, is also at a crossroads. And frankly, there is a lot of dissatisfaction going into COVID with institutional care, hospitals and whatnot. And it ties into a lot of different issues. And it's not every hospital. I know rural hospitals, and I know I'm talking in Kansas, and I know you have a lot of rural care. I'm not judging on any one hospital. There's probably, we know there are hospitals that none of these apply, and we need to make, policy decisions to support the care we need for our communities. That's fine. But more broadly, there is a concern, the way the employers have been charged, and the focus on quality and accountability and transparency. And so what we are pushing forward is a more accountable structure around episodes of care. And we've defined that collective agenda here. And I won't go through all that. Mental health, I think, the Kansas Business Group on Health is one of our reset regions. Kansas is one of our reset regions for the path forward for mental health and substance use. And we're just starting to get our legs under this. This was a system that was in crisis before COVID-19. But when you look at the numbers of what's happened in increasing the prevalence of mental health issues, this is a critical issue. This crisis has been exacerbated. The good news, telebehavioral health has taken off. There's been a lot of policy decisions that have been made on a dime. Things that we've been talking about for 10 years were made in a month. And we need to, again, re-examine it and make them permanent. And frankly, telebehavioral health may be the avenue we use to get healthcare professionals to support our populations more effectively. Again, all these folks that have been outside of networks. And when you talk about rural health, telebehavioral health obviously is a key access point for underserved areas in our states, right? That's a very important. But frankly, in many instances, we need to be able to go cross-state because there's not even enough psychiatrists in whole states to support that. But equally important is we need to be screening and testing across the entire system. And that's almost in every interaction we have. Why? We are looking at an error when a very high percentage of our population is likely to test at risk for things like anxiety and depression and whatnot. And we need to know about it and get you early. And then we need to deal with that. And we need to triage the more serious cases and get them the care they need. And also, if we provide measurement-based care, measure on the front end to determine whether there's an issue, and then remeasure to determine what we did actually had an impact, that improves outcomes by 20 to 60%. And to think that that is not the standard of care, again, is a crime. And it's not the standard of care in primary care, and it's not the standard of care in specialty care. That's a problem. So, and then finally, the integration of behavioral health into primary care. We talked about how primary care is the central core part of our system. We need to double down our investment in primary care, but we need to integrate it with evidence-based practices into primary care for behavioral health. I'm going to pivot just a little bit. I want to have some time left at the end. Social determinants, not a new concept, been around for years. And I think it has gotten legs in the employer community, maybe in the last few years. Frankly, a lot of employers have been a little wary of getting into social determinants, in part because these are social issues within our communities. And the question is, should I as an employer invest in those communities? And I think a lot of times there's been resistance to go there. I think what people are starting to recognize is these same social determinants that we're looking at here actually exist within our employee populations. The problem is we don't measure, we don't ask, we don't know. And so part of what we need to do is actually get a hold of that going forward. But I will make a statement that I think that as we have gotten more sophisticated and more holistic in our well-being strategies, I think we were already on a journey to start integrating community into our well-being strategies. And the way we have been thinking about it prior to COVID, this was all prior to COVID, is first we have to understand what are these issues in the community more globally, and then we actually have to understand what are those issues within our employee workforces specifically. Because if we're going to have ownership, we got to understand that it actually matters to our own employees. That's what's going to sustain our level of engagement. The second part of this is connecting to resources individually for our employees. If they have issues, how do we help support them? And then how do we invest to improve where there are pockets of opportunity, particularly where that happens? Now, I would say this whole dynamic has changed even in the last 2 months. And I'm going to bring that forward in just a second. Again, integrating social determinants by addressing needs, addressing people needs, and addressing community needs. And what does that look like? And the community needs can come from money, or it can come from employees. It can come from engaging in community initiatives. And again, I see both of those happening. And again, where there's a holistic way to think about how we manage well-being within our organizations, I think there are parallel things that happen across a community on how you engage within those communities on these issues. And so now I want to kind of pivot just a hair and say, and one of the things that has started to change this conversation in the last 60 days, and it's not even 60 days, coming up on 60 days, is the race and racial justice issues that have arisen. And interestingly, even before those hit, it was very apparent that Black Americans were being impacted by COVID-19 at a much higher level than white Americans. And not by 5%, not by 10%, not by 25%, not by 60%, but by 2 times as much as white Americans. 2 times, think about that, 2 times as much. And what contributes? We can all recite what contributes. Yeah, they have jobs where they're more exposed. Yeah, they have more chronic conditions. Yeah, they have. All the things is kind of the perfect storm that has really added all this level. And you would think that would have been a call to action, but it wasn't until George Floyd that all of us started waking up. And I think it was the George Floyd incident, and this actually came out in one of our town halls on race, health, and equity. It was the George Floyd, and not this COVID-19. The COVID-19 should have been a call to action, but it was the George Floyd incident that made it very clear that there is a bigger issue here than any of us can acknowledge and understand. And it's only till we open our eyes and start looking and thinking and talking about these things that we're going to better understand what got us here. Because if we don't understand what got us here, we won't be as invested as we need to be to help turn the tide. And my view is this is every bit like the virus. If you keep doing the same thing we've been doing, the trends are not going to get better. They're going to keep going in the same direction. You've got to look entirely new with an entirely new lens and a different way of looking at this. And that's what we're doing at the National Alliance, and I hope all of you will. And I'll share a little bit of how that's happening. So we actually have a series of town halls, and these are recorded. And frankly, these town halls, we've only done 2 of them so far, restarting the conversation and the unconscious bias in healthcare delivery. And I can tell you the notes I got after the second one, even after the first one, were unbelievable in terms of we have never talked about it at this level or with this level of transparency, and frankly, uncomfort when you start getting into these issues. These are really critical issues. The next 2 town halls, one will talk about the roots and impact of social determinants of health. Usually we start with the social determinants, say those impact healthcare and health of our communities, right? But I think we have to understand the roots of why we ended up there for us to fully appreciate why we own this issue. We all own this issue, and we need to work together to turn the tide on this. There is a need for us to repair the damage we caused. And we need to figure that out. And then finally, the race and equity lens on the employee well-being strategy. So more to come on this, and I really do hope you will engage on this. I do want to share a couple of slides that we did share on our first town hall, which is looking at race in the context of stigma. And when you think of stigma, we often think about things like that in the context of mental illness or substance use or overweight and obesity, right? And you see this model of stereotypes, prejudice, discrimination. All that model, when you look at that, you go, wow, that looks like race to me. And this model has nothing to do with race. It actually is the model of stigma. And then when you look at this same model in the context of the negative effects of stigma, and that's true of mental illness or anything that we have been involved in before, self-doubt and shame, isolation and secrecy, reluctance to seek help, restricted career or life opportunities, inadequate resources are covered, bullying, physical violence, harassment. That sounds like race too. And this was built on stigma, not on race. The good news is we have been involved in issues around stigma before. We know how to attack stigma. We're doing it on mental health today. We did it on cancer before that. We've done it on these areas before. And I think we need to go down some of those same paths with race. And one of the first things you do is you break the silence. You talk about it. You start the conversation and you normalize the uncomfortable situation so that we start the process. That's what we're doing in our town halls. But going forward, we also then need to deal with some of the issues as well. And so that same framework that we had before, understand the issues and the needs, connect to resources, invest to improve, I insert health equity in there. Because I think this is going to be the fulcrum that is going to galvanize us as coalitions and employers to invest in our communities at a level we never have before. And coalitions are going to be critical as we move forward. And when you bring it all together in our total person mindset, we live in this central bucket, this programs and interventions. This is what we do for a living. And we talk about the outputs in terms of, productivity and presenteeism, and increasingly on individual health and well-being, and even more so now we're actually tying it into organizational performance, why this leads to better sales or turnover, employee experience, and all that. What I would call our attention to, though, is let's go back and look at the inputs, that the diversity of the people that are in our organizations matter. And we need to look at the subsets within our organizations if we're going to get at total person health. We need to understand the social determinants. We need to understand the differences by race or language or ethnicity, age, gender. And we need to know the role the organization is playing that from a culture or leadership, et cetera. And frankly, we need to also know that the community has a big impact as well. So with that, I would just say, there are traps here. An easy trap is to say, oh, now I know what to do. You do, but you don't. And it's going to come through a change process. It's going to require engagement, listening, learning, going through all that individually, organizationally, and more broadly. And I think we have to kind of go through that. And then secondly, I don't know if we're collective. I don't know if we have time for this. Frankly, the people agenda has never been more central than the COVID-19 era. We're relying on these people to bring our companies and our organizations back, to bring our communities back. And if we don't care for them holistically, we're going to lose them and we're going to lose the war. So with that, I'll leave it at that. I hope we have time for questions.
Well, all I can say is, wow, Mike, I just don't even know. I can't really add anything. That was really, really great. And I hope that I'm not seeing a lot of questions, so I'm thinking people maybe are just really reeling from some of what you had to say. And I think that for me, because I, attend a lot of the National Alliance meetings, webinars, and that kind of thing, that I've heard it, but you really just all put it together in a really, really meaningful way. And I know that our business group on health is very committed to this. I think it is still something relatively new in the sense of people really understanding that. And I couldn't agree more that I think COVID is going to drive this to a place, whether we like it or not, that we are going to have to address. And I just so appreciate your words and your comments. I appreciate everything the Alliance is doing. And I would tell the attendees that if you are a member of the Business Group on Health, I know that's kind of a cheap pitch, but you have access to all of these resources and they are incredible. And I wrote a lot of different notes and only have a few minutes left before we're gonna end. But one of the things I did want to follow up on when you were talking about the town halls, and again, our members have access to those. They are awesome. And there have been a number of town halls kind of beginning with COVID and the ones more recently on race, health, and equity. You know, I considered myself pretty well educated in that space. And I listened to the one last week and it was amazing. I mean, I learned things that I thought I knew and I didn't know. And it is an open, candid conversation, and Mike leads it. And I appreciate his bravery in doing that, because truly it is an uncomfortable topic. I mean, I remember in starting my career and when I got into administration, you know, we were talking about cultural diversity. Well, we've come a long way since then, but I think that now is the time we can really rally around those issues and just all of the total well-being. One of the things, as I say, I had so many notes written down here, but and again, we are a reset region, and of course, mental health is very near and dear to me. I'm still a licensed therapist. I don't practice anymore, but I'm really excited about it. And I think that, you know, yeah, there's a huge opportunity right now. I think we're going to see more and more of that. I find that mental health and substance use isn't anything very, at least it's not really talked about too much, I think, in our area, and the understanding of that, and certainly the focus areas for this project. So we're excited about that. You know, and another thing that struck me, and I say this because we actually had one of our attendees email Matt and I and say, I have to leave now because we've had a COVID outbreak at, and I won't identify who it is, but at one of their facilities, and they have to tend to that. And it struck me because the timing was perfect from what you were talking about, that, you know, when we talk about our employees, and then we talk about our benefit professionals who are dealing not only with their own stress and anxiety about this, but then they have to deal with something like this, it truly is overwhelming. And so I really hope that we will come together, and certainly the Business Group on Health wants to be a part of that, to help you really understand and figure that out. And another thing I'm going to say, because I think you had on there some of the issues related to pregnancy. What we also know is, and I have a daughter who just found out she was pregnant. She's already been totally stressed out about COVID, and now she's more stressed out. And the thing we know about stress and pregnancy is it's not good for fetuses and for babies. And so it's just the whole thing. It is sort of overwhelming. But anyway, I'll quit yammering. We did have a question come up. Thank you. It says, do you envision health plans moving into reimbursing for things that contribute towards social determinants of health? For example, when a child is seen for asthma, offering to inspect the home for mold and air quality and allowing reimbursement of expenses that would improve the health in the home. That's a wonderful question. Mike?
I think we're early stage in all of this. I mean, we are looking at things with lenses we've never looked at in my history, and I've been around for a while. And I know when we're talking about the issues around race, health, and equity, for example, and those, I talk about those as if they're intertwined with social determinants, and they're not the same, but they are clearly interrelated, right? So, and this race, health, and equity agenda is driving that train, in my opinion. That is what is going to cause us to take action we've never considered in the past. And we have even had conversations with our partners around episodes of care, bundled payments, saying, how do we get the metrics right to reward equity as well? That how do we think about what is accountability for whom? Accountability for the average or accountability for everybody? You know, a lot of this is shifting from a mindset of averages to a mindset of nobody left behind. And with that in mind, I think you start investing in a different way. And again, the reason you'll invest is because you realize that you help contribute to the problem. And I think not just that it's impacting you directly, but we all contributed to get us here, and we've got to contribute to get us out of it.